Can you tell us a little bit about chemosensitivity testing? I think that's also a really exciting aspect to the work you do.
Yeah, so we don't take the opinion here that conventional therapies are bad therapies. They do have a high level of toxicity, and they're not something anybody wants to do. And we have a lot of patients coming in saying, "I want to try a natural route." I'm not comfortable letting patients just do a natural route without doing a conventional route when they have an active cancer. Once cancer's taken root, I feel like they need conventional care to pull the weed. And then we can take it over from there. We can do things like hyperchelation and all the supportive therapies we do. But when patients have an active cancer, they typically need conventional care. The way that care is practiced in the oncology model is it's based on standard of care. And standard of care is based typically on how the average patient is going to respond to treatment. That doesn't feel so great to me, because I want if it were me or my own patients, I don't want them treated like the average patient. I want treatment to be customized. And there's various modalities out there that can help with customized cancer care. There's a lab that we use called Keras Diagnostics. It does molecular intelligence reports, which does genetic and molecular profiling on someone's tumor and gives us a slew of data about that tumor that tells us what they're most likely to respond to. And then the place I've seen the best results with are two labs in Southern California, Weisenthal Cancer Labs and Rational Therapeutics, run by an oncologist named Robert Nagorny. And what those labs do, that's chemosensitivity resistance testing, where they'll actually they need live tissue, so a biopsy or a surgery needs to be done, they need live tissue FedEx to them, and then they'll grow out the cancer cells in test tubes with various chemo agents. Sometimes they can use natural agents too. And they'll come back with a report saying what agents you're most likely to respond to and what agents you're least likely to respond to. So if you're going to need to go through this therapy, which is a toxic therapy, which nobody looks forward to, at least we're getting some data saying your particular type of cancer, you have a high likelihood of responding to this, you have a high likelihood of not responding to this, and we can really target and focus the treatment. It's important that the patients treating oncologists are on board, because they're the ones who are going to have to work with this. But we try to kind of be an advocate for the patient and work in the middle between the patient and the oncologist to see if we can make that happen as much as possible.
Mm-hmm.